The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we are thrilled to have Dr. Whitney Brandt here to review the management of all things lung and mediastinal disease.
Great to be here. Thanks for having me.
Dr. Brandt is a thoracic surgeon at Washington University in St. Louis, and Dr. Puri, who could not be here with us today, is the senior author of this chapter, Lung and Mediastinal Diseases. My name is Louisa Bai, and I am a general surgery resident here at WashU, and will be your host for this episode. So lung and mediastinal diseases cover a broad topic, this chapter, from benign and malignant pulmonary, pleural, and mediastinal pathologies and treatment. Esophageal diseases will be covered elsewhere in another chapter, and today we'll go over a selection of case scenarios representing the most commonly encountered thoracic problems. Let's dive right in. All right, Dr. Brandt. A 28-year-old male presents to the emergency room with acute onset shortness of breath and left-sided chest pain starting 4 hours prior. His heart rate is 105, blood pressure is 150/85, and saturation is 90% en room air. What is on your differential diagnosis?
So in this 28-year-old who presented with chest pain, I would think, one, about pneumothorax, but I'd also think about, aortic dissection, tension pneumonia, or any cardiac or musculoskeletal causes.
Great. And how would you like to work this patient up?
Well, first I do a physical exam. I listen to the heart and lungs, examine the neck for tracheal deviation or distended neck veins. I'd want an upright chest x-ray, and then I get an ABG if he is still desaturating, and then a possible chest CT if the chest x-ray is normal, and an EKG.
All right. So a chest x-ray reveals a moderate left pneumothorax without mediastinal shift or tracheal deviation. He's now saturating 92% on 4 liters of oxygen. Okay. How would you like to treat this patient?
Sorry to interrupt. Okay, so I would continue the supplemental oxygen just to keep his O2 sats up. And then I would talk to him about a chest tube placement. It's not urgently placed, so he's awake, and I'd kind of go over the risks and benefits to that. But we can place a chest tube, given that he's a healthy young male. We can use a small bore chest tube like a Thalquick or one of those such chest tubes. And then I'd repeat a chest x-ray after placement to confirm that the lung re-expanded, and I'd check the chest tube after insertion for an air leak.
Great. Now, let's say this patient comes into the ER about 3 months later after an uneventful first hospital course. He comes in with a recurrent left spontaneous pneumothorax. How would you manage this patient at this point?
Okay, so at this point, the first time pneumothorax you can treat with just a chest tube, and if the lung re-expands and there's no air leak, then they can go home as you suggested. But if they can have another pneumothorax on the same side, then you have to figure out why. So first thing we usually do in patients that are adult, we usually get a chest CT and look for blebs. If there aren't any blebs, then we can talk to them about doing a wedge resection and plus or minus a pleurodesis. We usually do this here with a video-assisted approach, so we make small incisions with the camera, go in, take a wedge out of the bleb. If we see one, they're usually at the apex of the lung or in the superior segment. And then we can do a pleurodesis either with mechanical or chemical or a mixture of both.
Excellent, Dr. Brandt. Thank you for all those pearls. Now let's move on to the second case. A 64-year-old male presents to your office with an incidental 1.7 centimeter right upper lobe nodule found on low-dose CT done for lung cancer screening. He has a 30-pack year history, smoking history, and is otherwise healthy. And he denies any cough, dyspnea, or recent weight changes. How would you work up this patient further?
Okay, so in anybody who comes in with a new nodule on their lung scan, you should be concerned about lung cancer, especially if they're a smoker and in this age range. So it could be lung cancer. You'd want to know about previous other cancers, just in case it were a metastasis, but it could also be benign lesions. So I'd look at the CT scan. I'd see if there are any older CT scans to compare that can tell you if it's growing or if it's changed at all. And then I'd want to know exactly where it were in the chest. So if it's peripheral, it might be easy to biopsy via a percutaneous biopsy. And if it's more central, then you can use a bronchoscopy to biopsy it. I'd also, if it's 1.7 centimeters and solid, then I would want a PET scan to see if there's FDG avidity in the lesion or any evidence of distant disease, especially in the mediastinum.
All right, great. So let's say that this particular nodule was amenable to biopsy by the pulmonologists, and it was found to be in the middle of the right upper lobe. It was clinical stage 1 disease, non-small cell lung cancer. How would you approach this patient's treatment?
Okay, so first I would make sure the pulmonary function tests were okay. So I'd make sure the FEV1 and DLCO were greater than 40 predicted after I would take out the right upper lobe. You can calculate that by looking at the number of segments in the right upper lobe and the number of segments that would be remaining after. And then I would talk to the patient about doing my favorite approach, robotic right upper lobectomy, and to some mediastinal lymph node sampling at the same time.
Excellent. Would you be able to run us through the main steps to a right upper lobectomy?
Yeah. So you can do this like robotically, video assisted, or via thoracotomy. The first step really is to start with the vein isolation. So you can actually release the anterior hilum, find the upper lobe vein. At the same time, you're getting the lymph nodes that are around the vein and the artery. Once you're pretty clear that they don't have metastatic disease, you can start by taking the right upper lobe vein, taking care to spare the middle lobe vein, then start dividing the PA branches to the right upper lobe. You need to get the truncus anterior and then the posterior ascending artery to the right upper lobe. At the same time, then you remove the mediastinal and hilar lymph nodes, and then you can take the right upper lobe bronchus. Once that's done, you can divide the parenchyma between the right upper lobe and the other two lobes, the middle and the lower lobe, and then you can remove the specimen. And if you have enough lymph nodes, then you can be done with the case. You can place a chest tube at the end and then wake them up.
All right. And we talked about a lobectomy here. When would you consider doing a wedge resection or a segmentectomy?
So it used to be that every patient with a lung cancer was supposed to get a lobectomy via an old trial that was done many years ago. But more recently, in the past couple of years, there have been 2 randomized controlled trials that looked at sublobar resection and lobectomy for lung cancer for peripheral lung cancers that are in the outer 1/3 of the lung. And in those cases, they found that a sublobar resection was equivalent to a lobectomy in those cases. So if it's less than 2 centimeters and located in the peripheral third of the lung, you can do a wedge or sublobar resection with mediastinal lymph node sampling with equivalent outcomes.
Excellent. All right. Now let's move on to post-operative management. What are the most common complications post-lung resection?
Well, the most common is probably an air leak. So especially if you do a lobectomy, or segmentectomy, many patients get an air leak, meaning that the air is still coming out of their chest tube. It's really defined as greater than 5 days, and you can either treat those patients with a bedside pleurodesis, or sometimes if their lung is staying up on water seal, you can send them home with a chest tube and wait for their air leak to seal. We also commonly get patients who go into atrial fibrillation or aflutter. Usually happens within the first couple days of surgery, and the treatment for that is to correct the electrolyte imbalances and try to rate control with beta blockers, and sometimes you can cardiovert them if they are unstable.
All right. And just wanted to circle back. We talked about a stage 1 disease. If you were faced with a stage 2 or early stage 3 patient with stage 2 or early stage 3 disease, how would you change your approach there?
Yeah, great question. So anyone with stage 2 disease or greater preoperatively needs an MRI of the brain to make sure they don't have distant mets in addition to what we talked about. Anyone with a greater than 3 centimeter primary tumor and no nodes even needs mediastinal staging, so they need an EVIS or something of that sort. And in anyone with 3A disease, you should definitely talk to the oncologist about induction, chemotherapy, and immunotherapy together, followed by surgical resection. And it is reasonable on anyone who has stage 2 disease, either large or node negative, or anyone with node positive N1 disease would get induction chemoimmunotherapy as well.
All right. And finally, in a patient who is not able to tolerate surgery at all or any lung resection, what options are available?
So for those patients, if it's a low-grade lesion, you can talk about watching them, especially if they're older. But the best alternative therapy right now is called SBRT. That's high-dose radiation to the lesion.
All right, great. Now let us move on to the third case. A 32-year-old female presents with 6 months of double vision and slurred speech at the end of each day. How would you work this patient up?
Okay, so this sounds like this patient might have myasthenia gravis. That's usually what thoracic surgeons get sent for with this kind of symptom. So you need to assess for the presence of a thymoma. So first you talk about the symptoms, you see if they've seen a neurologist, but then obtain a chest CT to look and see if there's any thymoma or enlarged thymus.
All right. So this patient undergoes a chest CT and is found to have a 6-centimeter anterior mediastinal mass. She has no other medical problems and no past surgical history. What is your next step?
Well, for number one, you want to make sure that the myasthenia gravis is under control. So you can talk to the neurologist and make sure that that's under control with medical management. And once they get the maximal medical management, then you can talk to them about doing a thymectomy. That's indicated for anyone with myasthenia gravis with or without thymoma because it improves symptoms in both cases.
All right. And what would you recommend for the surgical approach, or how would you counsel the patient on the various approaches available?
So in a patient with a large thymoma such as this, you want to make sure it's not invading anything. So you can look and see if it's invading the pericardium or any of the phrenic nerve on either side, which would control the diaphragm. But really, in patients who have any symptoms of myasthenia gravis, you have to make sure you remove the entire thymic gland, even if they have a thymoma. So usually you can do this via a couple different approaches. You can do, if it's small enough, a robotic bilateral or VATS bilateral thymectomy. So you would have to make incisions on both sides to free things up anterior to the phrenic and then release the whole gland. And if it is big, then you're going to have to do a sternotomy to remove it.
All right, excellent. Now we're rapid firing, going through here. We'll move on to our fourth and final case. A 54-year-old female that underwent bilateral lung transplantation 2 days ago for idiopathic pulmonary fibrosis becomes increasingly difficult to oxygenate. She has a PaO2 of 144 millimeters of mercury on 100% FiO2, and her chest x-ray shows increased bilateral pulmonary infiltrates compared to the day prior. What are you most worried about?
So in anyone that has a lung transplant that has poor oxygenation postoperatively, you want to think about primary graft dysfunction. The severity of that's defined by the PaO2 to FiO2 ratio, measured at 24, 48, and 72 hours post-transplant. And you can look on the x-ray to confirm there's usually pulmonary edema. Sometimes it's bilateral or on the offending side of the PGD. And this patient has severe grade 3 PGD with a P to F ratio less than 200, and she has evidence of pulmonary edema.
All right. So let's say this patient is treated through with supportive care and ultimately recovered and was discharged home following her transplant. 3 years later, she returns to the office complaining of a 3-month history of a non-productive cough and worsening dyspnea on exertion. What are you concerned about at this point?
So it could be a lot of things. You know, she's on immunosuppression, so it could be an infection, but you'd also have to keep your antenna up to make sure she's not having some sort of chronic lung allograft dysfunction or CLAD that could equate to chronic rejection. And we know that PGD, like this patient had, is a risk factor for the development of chronic rejection.
All right. And how would you diagnose CLAD or chronic rejection?
It's defined by greater than or equal to 20% decline in FEV1 compared to the post-transplant baseline. So you can look at that, but you can also obtain a transbronchial biopsy to obtain tissue for a more definitive diagnosis.
All right. And finally, how would you approach the treatment of CLAD?
So for these patients, you have to work with your pulmonologist, optimize their immunosuppression, could administer azithromycin. However, the disease is often progressive and refractory to treatment, and ultimately she may require retransplantation. It's usually the main barrier to long-term survival in lung transplant recipients.
All right. Thank you so much, Dr. Brandt, for being here with us today. We got through a ton of great information on lung and mediastinal diseases. As always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes, as well as a full review of the topic can be found in the Washington Manual of Surgery 9th edition.
Thanks for having me.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine And we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams and Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.